Hello, my dear students. On this short module, we are going to discuss bronchial asthma and the cough, the drugs used for bronchial asthma and cough. At the beginning of this particular module, I want you to remember 2 or 3 important things. Nowadays, according to the advanced thought, bronchial asthma is thought to be an inflammatory disorder. You need to keep this in mind. That's one. Second important thing is in bronchial asthma, the antibody which works mainly is IgE antibody, and this IgE antibody is present on the surface of the mast cell. That's the second important thing to remember. The third important thing I want to tell you is the formation and synthesis of leukotrienes. Arachidonic acid is the precursor, and this arachidonic acid can take 2 pathways. The first pathway is called the cyclooxygenase pathway, and this leads to the formation of prostaglandins. The second pathway is the lipoxygenase pathway, and this lipoxygenase pathway leads to the formation of leukotrienes. What I am saying is, leukotrienes have been thought to have very important role in the management of bronchial asthma. So we have 3 things to remember. Number 1, it is thought to be an inflammatory disorder. Number 2, the IgE antibody present on the surface of the mast cell. And number 3, the synthesis of leukotrienes. Okay, let's go on to discuss the drugs used for bronchial asthma. We divide them into short-term relievers. Look at your slide. The short-term relievers include bronchodilators, and the bronchodilators are beta stimulants, xanthine alkaloids, and anti-muscarinic drugs. There is another group of drugs used for bronchial asthma, and they are the long-term controllers. The long-term controllers include corticosteroids, the drugs acting on leukotrienes, and the mast cell stabilizers. So this is the mainstay of classification of the drugs used for bronchial asthma. We start with the short-term controllers, that's beta stimulants. I remind you of epinephrine, which is useful in acute attack of bronchial asthma, stimulates the beta-2 receptor in the bronchus and leads to bronchodilation, and also works as the physiological antagonist of histamine. The second drug, which could be useful, is ephedrine, is a bronchodilator, but it's a non-catecholamine, and the non-catecholamines cross the blood-brain barrier and lead to central nervous system stimulation. The third important agent under the beta stimulants is isoprenaline. Isoprenaline is used by sublingual route of administration to terminate an attack of bronchial asthma, but as you know, isoprenaline is non-selective. It acts on beta-1 as well as the beta-2 receptors, and when you give a drug by sublingual route of administration, it enters the systemic circulation, and the beta-1 receptors are present in the heart, and isoprenaline is going to produce cardiac adverse effect and cardiac stimulation. So these are comparatively non-selective beta stimulants. The next slide is telling you about selective beta-2 stimulants, and these selective beta-2 stimulants are expected to have minimal effect on the beta-1 receptor of the heart, and hence you expect less cardiac stimulation. The first very widely used agent is salbutamol or albuterol, and the second one is terbutaline. What's the difference between the two? Terbutaline has got a longer action. That's the difference between salbutamol and terbutaline. Both of them are available by the route of inhalation. They're available as tablets and syrups to be used by oral route of administration. There are more selective beta-2 stimulants in the form of pirbuterol, bitalterol, and metoprolol. I would like to tell you about 2 more agents which are selective beta-2 stimulants, but they are long-acting. The first one is salmeterol, and the second one is formoterol. Yes, they do produce bronchodilation when you inhale them, but their effect is more sustained one. They are available by the route of inhalation. They are not yet available by oral route of administration, and they are useful in the long-term prevention of bronchial asthma. The second group in the bronchodilators was xanthine derivatives, and these are the inhibitors of phosphodiesterase 3, and they lead to increase in the cyclic AMP, namely theophylline, theobromine, caffeine. And the last one, important to remember, is aminophylline. Once upon a time, this aminophylline was drug of choice for acute attack of bronchial asthma. What's aminophylline? It's a soluble derivative of theophylline. It's theophylline ethylene diamine. And the dose is 250 milligrams in 20 milliliters of 20% glucose injected by a very slow infusion by intravenous route of administration for acute attack of bronchial asthma. These drugs also do inhibit the adenosine receptors. Theophylline is also available by other routes of administration, that's the slow release formulation in the form of a tablet or the oral tablet. Xanthine derivatives are going to increase the cyclic AMP, and this is going to produce the adverse effects in the form of cardiac stimulation. They are also likely to lead to tremors and nervousness. The next group of bronchodilators we already discussed in anti-muscarinic drugs. They are the anti-cholinergic, anti-muscarinic agents, and these are the derivatives of atropine. These are atropine substitutes. There's apratropium and there's tiotropium. Tiotropium is longer acting and has got a slow onset of action. Both these agents are useful. They are long acting. They can also produce bronchodilation. There is less dryness as compared to atropine, and they're useful in patients with chronic obstructive pulmonary diseases and the patients who are chronic smokers. So this is about the short-term relievers. Now we come to the long-term controllers useful in bronchial asthma. The first important group is inhaled corticosteroids. The second one is drugs acting on leukotrienes, and the third important group is the mast cell stabilizers. But I would like to remind you, I just said about formoterol and salmeterol, which are long-acting beta stimulants, which are used locally, thus by the route of inhalation. Although I included them in the short-term relievers because I wanted to put the beta-2 stimulants there, but please remember, salmeterol and formoterol could be useful for long-term control of bronchial asthma because they have got a longer duration of action. We come to the inhaled steroids, and I just mentioned at the beginning of the module that bronchial asthma is considered as an inflammatory disorder, and here's where the steroids act. When you inhale a corticosteroid, it's thought to produce following mechanisms of action. The most important mainstay of the action is to decrease the bronchial hyperreactivity or the decrease bronchial hyperresponsiveness. So the bronchus, which was earlier responding in a hyper way, in a higher way, is going to decrease its hyperresponsiveness. And this is happening due to the corticosteroids. What are the associated effects? They have anti-inflammatory action, they decrease the mucosal edema, they decrease the cytokines, they decrease the lymphocytic and the eosinophilic infiltration. Various steroids could be used in the form of budesonide, triamcinolone, flunisolide, and mometasone. But we need to remember one agent which is most widely used and is called beclomethasone dipropionate. Beclomethasone dipropionate. What are the adverse effects expected if you use it by the route of inhalation? Because of the repeated inhalation, you're likely to get the oropharyngeal candidiasis, and it's because the use of corticosteroids favors the opportunistic infections. Oropharyngeal candidiasis produced in this way is treated with the help of nystatin, which is an antifungal agent. Another adverse effect you expect is hoarseness of voice. If the inhaled steroids go into the systemic circulation, they are likely to produce systemic adverse effects. But the way we are using them, we expect minimal adverse effect, systemic adverse effects with inhaled steroids. Some steroids are useful in emergency, and the emergency in bronchial asthma is called status asthmaticus. The patient is suffering from bronchial asthma, he is already on various drugs, he had an acute attack of bronchial asthma, this was managed with salbutamol inhalation or with epinephrine, but still the patient is breathless, then you call it status asthmaticus, and you can inject hydrocortisone hemisuccinate, 100 milligrams intravenous is the standard dose, and this is going to relieve the status asthmaticus. So it's a corticosteroid used only in emergency by intravenous route of administration. More corticosteroids in the form of dexamethasone and betamethasone could also be used by intravenous route of administration. Next we come to the drugs acting on leukotrienes, and as I said, the arachidonic acid metabolism takes this pathway, that's a lipoxygenase pathway, and leads to the formation of leukotrienes. The cystinyl leukotrienes are leukotrienes C4, D4, and E4. They lead to hyperreactivity of the bronchial smooth muscle, they produce edema, and they increase the mucus secretion. LTB4, that's leukotriene B4, also takes part in the neutrophilic infiltration. I would like to remind you that aspirin or salicylates are the drugs which enable the cyclooxygenase enzyme and lead to decreased prostaglandin synthesis. But when this happens, the arachidonic acid is likely to go to the other side and take up the lipoxygenase pathway and lead to the synthesis of leukotrienes. And this is how aspirin is responsible for precipitating bronchial asthma. That's the reason we say in patients who are having bronchial asthma, aspirin or salicylates are contraindicated. So aspirin-induced asthma is due to the liberation of leukotrienes. Now, could we do anything to the leukotrienes? Yes, we have various approaches. Number one, the enzyme 5-lipoxygenase could be inhibited, which is responsible for leukotriene synthesis. So we have a drug which inhibits 5-lipoxygenase and decreases the leukotriene synthesis. Name of the drug is Xyluton, and very fortunately, it's available by oral route of administration. The second approach could be the leukotrienes which are synthesized, they are going to act on the leukotriene receptor. And you have a drug which could block the LT1 receptor, that's the leukotriene 1 receptor. Not drug, there are two drugs which are available. These are leukotriene receptor antagonists in the form of zafirleucast and montelukast. They are available by oral route of administration, and once or twice daily administration suffices to manage the bronchial asthma. What's the importance of zafirleucast and montelukast as well as Xyluton? The importance is, if you have a child suffering from bronchial asthma, it's very difficult to train a child to use an inhaler. And this particular route of administration especially poses problems when you want to use an inhaler for the children. These two drugs, zafirleucast and montelukast, as well as Xyluton, are available by oral route of administration, and that becomes very valuable as far as managing the bronchial asthma in the children. We come to the next group, and that's called mast cell stabilizer. I told you the IgE antibody, the reagenic antibody, is very important in bronchial asthma. IgE antibody is present on this mast cell surface, and when there's an antigen antibody reaction, the mast cell breaks and there's degranulation of the mast cell, and the granules inside the mast cell, they liberate histamine, not only histamine, various chemical mediators which are responsible for asthma. So if you could stabilize the membrane of the mast cell, then you could prevent an attack of bronchial asthma. We have cromolyn sodium or disodium chromoglycate, and we also have nidochromyl sodium. These two drugs are mast cell stabilizers, and they prevent the degranulation of mast cell. A very important thing to remember is, when the degranulation of mast cell is going to happen, right before that, your drug has to be there to prevent the degranulation. There is no use of giving cromolyn or nidochromyl when the patient is coming to you in acute attack of bronchial asthma. When the patient is already having breathlessness, it means that the mast cell is already broken, is already degranulated, and all the chemical mediators of asthma have been already released. There is no use of giving cromolyn or nidochromyl in this situation. Cromolyn or nidochromyl has to be present, and it's going to prevent the degranulation of mast cell. They are useful for asthma. They are also useful as nasal drops for management of rhinitis and as eye drops for management of conjunctivitis, that's for preventing the attacks. In asthma, cromolyn sodium is available only by the route of inhalation. We don't have tablets and we don't have injection for cromolyn sodium, and it's got very important value in prevention of attack of bronchial asthma. It's not useful when the attack is over. I'm asking you a few questions after you heard about cromolyn. You can have a look at the slide. Question number 1 about cromolyn. Does it dilate the bronchus? The answer is no. It's not a bronchodilator. Otherwise, I would have put it in short-term controllers and I would have called it a bronchodilator. Question number 2. Does it prevent antigen-antibody reaction? No, it doesn't prevent the antigen-antibody reaction. Antigen-antibody reaction could happen, but it's going to stop the degranulation of the mast cell. Does it prevent combining of antigen to the antibody is the third question. Because at each stage, every stage, you could expect the drug to act. Does it prevent combining of antigen to the antibody? No, it doesn't prevent the combination of antigen with antibody. One more question. Does it block histamine receptors? Is it an antihistamine? No, it's not an antihistamine. It doesn't have any antihistamine effect. The last question is, does it prevent degranulation of mast cells? Yes, you're right. That's the green letters you see. It prevents the degranulation of mast cell. Just because I ask you a question, does it block histamine receptors? Let's give a little bit of importance to antihistamines. Antihistamines, once upon a time, were used symptomatically in the management of bronchial asthma. But it was found that antihistamines are not useful to manage bronchial asthma. What's the reason? If histamine is the substance responsible for the attack, why antihistamines are not useful? There are two reasons. It's not only histamine. There are more chemical mediators which are precipitating asthma. And as I said, nowadays, what we think is leukotrienes are the main culprit, and antihistamines are least likely to have any effect on the leukotrienes. That's reason number one. Reason number two, antihistamines, when you start giving them by oral route of administration, they are less likely to achieve an effective concentration at the site of action. And this is why antihistamines are not useful in bronchial asthma. Let's come to the next slide to see the newer agents useful in bronchial asthma and what's the future. Amongst the newer agent, we have one agent available. It's called omalizumab. It's ending with the spelling MAB, which tells you it's a monoclonal antibody. Omalizumab is a monoclonal antibody to the IgE antibody. So it's anti-IgE antibody. It inhibits binding of the IgE antibody to the mast cells. So that's a novel mechanism of action. As far as the future is concerned, we can think of potassium channel openers in the form of chromocalim. We can think of a monoclonal antibody against interleukin 4, interleukin 5, and cytokines. After discussing the drugs useful for bronchial asthma, we briefly discussed the drugs used in the management of cough. You have pharyngeal demulcents, which are soothening agents, and the examples are glycerine and liquorice. We have expectorants, which are the mucokinetic agents, are going to stimulate the kinases, the mucokinases. We have directly acting agents in the form of sodium potassium citrate, potassium iodide, and guaifenesin. We have a reflex acting agent, that's ammonium chloride, and you also have potassium iodide here, which has a direct action as well as reflex action. And lastly, you have mucolytic agents, which have got an extreme importance, and a very useful agent is bromhexine. I have highlighted on the slide a drug called acetylcysteine, which is a very useful mucolytic agent in very serious type of cough, which is associated with diseases like cystic fibrosis. The third group, which could be useful in cough, is antihistamines, and of course, they are producing symptomatic management in the cough. The last group is called antitussive agents, and the meaning of the term antitussive is cough suppressants. They are going to suppress the cough. So which cough is to be suppressed? The cough which is dry is to be suppressed. So antitussives are to be used for dry cough. If the cough is productive and is bringing out sputum, then you expected to use the expectorants. So if the cough is not dry, it's a wet cough, you are expected to use the expectorants. If it's dry cough, we need to use the antitussive agents or cough suppressants. Which are these cough suppressants or antitussive agents? There are two groups of antitussive agents. The first group is, of course, opioids. And I hope you remember, morphine is a cough suppressant, and various derivatives from the same group can have the cough suppressant effect, like codeine and volcodeine, which are age-old therapies for management of cough, and they are cough suppressants. The problem with these drugs is they are acting on the central nervous system, and they are central nervous system depressants. So if you drink volcodeine or codeine, you're likely to have drowsiness, you're likely to have CNS depression. So it's not good to use the sedative type of drug in the management of cough. We have newer drugs which are non-opioids, and they are non-narcotic antitussives. Narcosis is CNS depression. Non-narcotic, they are less likely to produce the CNS depression, and they'll produce the cough suppressant effect. Some of the important names are noscapine, dextromethorphan, carbetapentane, oxaladine, and pipazetate. Non-opioids do not produce the central nervous system depression. That's very important thing to remember. So we briefly went through bronchial asthma, but we went through some important facts and some important drugs useful in the management of bronchial asthma as well as useful in the symptomatic management of cough. I hope you enjoyed the module and it will be useful to you. Take care. All the best. Thank you.